about a few seconds, we'll have some people joining onto the session. Thank you, everybody. Wonderful. Well, thank you, everyone, for logging in to our Wellness Wednesday live webinar. This is a platform focused on health and wellness with guest speakers and specialists answering your questions about your physical and mental well-being. My name is Zarmina, and I'm delighted to be on this journey with you today. For today's session, do remember you may share your questions for our speaker through the chat feature on this webinar, and we will get to them in the second half. A little bit about our speaker today. Dr. Pamela Munster is a professor of medicine at the University of California, San Francisco, where she is the leader of Experimental Therapeutics Program, director of early phase clinical trial units, and co-director of UCSF Center for Breast Cancer Research. Dr. Munster recently authored a book titled Twisting Fate about her experience as an oncologist and a cancer patient. Thank you so much for being with us this morning or this evening, wherever you might be, Dr. Pamela. So nice to have you on this session.
Thank you for having me. It's a pleasure to be here, and I'm excited to talk to you.
That's awesome. And we would love for you to share a little bit about yourself, your personal life, your professional life with our viewers who would like to know you on a different level today. And for those who may not know you yet, please introduce yourself if you would.
Hi, I'm a professor of medicine at the University of California in San Francisco. And from my accent, you may or may not hear that I'm not a Native American. I grew up in Switzerland. I completed medical school in Switzerland, in Bern, and then had a passion for research and moved to the United States, where I got stuck. Once I got stuck in the United States professionally because I really fell in love with the research part. And then I fell in love with a man who also was in the neighbor lab, who happens to be, his family lives in Dubai, so my connection with Dubai. And then, so we have been partners, and we shared kids together. We have 3 kids, and we have been partners in medicine for many years. My passion has always been breast cancer and breast cancer research. And as most of you somehow know, is like, and then my passion turned into my disease. So I learned and got to see the disease I'm an expert in from the other side, from the patient side. And not that I ever wanted this, but I feel it has given me a very unique perspective that I would otherwise not have.
Wow, well, that must have been such a pivotal moment in your life. Could you walk us through that phase where, from being a treating physician, how were you diagnosed? What was that moment like? And how did you reach that point where you understood that that's what you're facing right now?
Like everyone who has ever been diagnosed with a disease of any kind, I think the first reaction is like disbelief. I think you think like, how can that be? I think very few of us sit here waiting for bad things to happen. So most of the time is disbelief, and then you think like, well, why me? And how can that be? I'm feeling fine. How can I have breast cancer? And then you start thinking like, okay, what are the next steps? And I think there's where people turn into different into their back to their own personality. They are the people who see a problem, they immediately want to tackle it. And the other people, they see a problem and they go like, let's hold off and let's not deal with this for days. And I think for me, it was more like, okay, I have a problem. What do I do next?
And do you think that was affected by the fact that you are in the medical space and you're a medical professional, and it impacted your approach to managing it?
Yeah, no doubt. You know, it's in, and I speak a little bit why we built the BRCA Center for Research. It's like, but no doubt, it's like, you know, the key part is whenever you're faced with an adversity or a problem is like, where are the experts that help you with getting through this, right? And for me, it was like, fortunately, the experts were essentially all my friends and colleagues. And I have to admit, it's not always good to know too much, but clearly it was very helpful to know a lot.
Absolutely. And And did you have a family history? Had you dealt with this before on a personal level? Or was this very unexpected for you?
No, actually, that was the unexpected part. Is like my grandfather, my grandmother had breast cancer when she was 62 or 63. And that was, she had a very small cancer. They cut it out. And that was when I was 7. So, and remember, that was in the times when no one actually talked about cancer. So my grandmother's cancer was not something that anyone was even aware of. So she had a small cancer, dealt with it, and never ever talked about it. And I think I've written a chapter about this in my book, just imagining how lonely in those days men and women were with their disease. Can you imagine having breast cancer and you cannot talk to anyone about it?
And there was not as much community support as there is now with, you know, the Friends of Cancer group and people supporting you who may have gone through it, or who are currently going through it. I think, like you rightly said, it perhaps was a taboo to share and to share that experience, and the fear perhaps of undergoing that alone.
Mm-hmm. And you know, as I said, my grandmother, when she found her lump, she was on vacation with us. We lived in Switzerland. My grandmother lived in Berlin. She found a lump, and she just went home with the excuse that she had found something or she needed to go home. I think she told my mother that she was worried, and that was the last time we talked about it. It was really, this was really taboo at those days, and it's very taboo in still in many countries. And I think part of our educational goals is also to really overcome this. You cannot get proper help and support if you don't talk about it.
Yeah, that's very well said, and I think a good reminder at this time. And I just want to ask you, Dr. Pamela, how did you go into the specialty? Was it a conscious choice? Did you just find yourself, leaning towards, being a specialist and researcher in this area?
Yeah, I was my first research was actually in cardiology. And my very first my MD thesis was in orthopedic surgery, and I was slated to be an orthopedic surgeon. And I have to say, though, in Switzerland, when I grew up, most of the people going to orthopedics were actually tall, good-looking men, and I just did not feel like fit the demographics. And so I decided, okay, I'm going to pivot. And my research was in cardiology, but I didn't like cardiology either. And then I had a mentor in oncology, who was just one of these, Larry Einhorn, the man who cured testicular cancer. And he was just such an inspiring figure, and he was so supportive, and he was this amazing man. And and I think he instilled in me the love for oncology. And you know, being an oncologist, we deal with a lot of patients who have sadness, who deal with challenges, and I've never been a person who shies away from challenges. So this was a bit my calling, and the research around breast cancer was a natural fit. I'm very comfortable with cancer patients, because I think I can understand, and at the same time, I don't get bogged down by sadness. So I don't take everything home. So I feel like I have enough resources to deal with it. And I think that was a big question when I was diagnosed. Do I want to continue this, or is this going to be too close? There was a time when I had to make an active decision. Do I want to stay as an oncologist, or do I want to do something else? Wow. And I felt like I now have two perspectives, and I might as well use it and stay with this.
And that's exactly what I just wanted to ask you. How is your journey of going through your diagnosis and recovering, how is it, or if at all, affected your interaction with your patients that you were treating?
I think the most classic event that happened is, like, I was talking to a patient who just had gone to a mastectomy, and was talking about restrictions and what she can do and how she couldn't do exercise and she couldn't do this. And she said to me, like, you just don't understand. And I said, yes, but I do. And I know how hard this is, and I know how important this is for you to get through this. And I think as a professional, I've always been good to making professional recommendations. Mm-hmm. But I think as a patient, I've learned to be a little bit more of a coach, in a sense, like if someone really struggles with keeping up with the reconstruction, rehabilitation, and the physical therapy, and people don't want to do it, I'm more a little bit in a better position to say, like, no, you really have to do this.
Right.
Does that make sense?
Relate to them, and they can probably reciprocate that. And a lot of the work that you do, and this whole awareness and research around this topic, it's really advocating for education and early detection. In your professional experience, what do you find are the common misconceptions or mistakes that you see frequently and would advise against to somebody maybe that has not been diagnosed yet or is not going for their frequent checkups as advised by their physician, or even diagnosed and undergoing this journey?
There's mainly what I see as two crucial parts. One is, we know that mammography helps detect breast cancer. What we don't know for sure is like how good it is under the age of 40. This clearly is not very helpful. Even between 40 and 50, mammographies may not be as good. Over the age of 50, I think everyone agrees women should be regularly screened. And I think that's an important part. And then if you have a family history of breast cancer, the screening becomes much more intense. We start doing MRIs starting at sometime already at 25. So we really need to be very aware that if you have a family history, that we want to screen you early. And family history can manifest in different ways. It can be a father with a pancreatic cancer. It can be a mother with ovarian cancer. It can come from the father's family. So these, and we talk about family history in just a little bit, but the second point that is even more important, and that's what I see a lot more in the Middle East and in Dubai, is someone feels a lump and it's tiny, and then they just don't come in for another 6 or 8 months, and that's the time where the crucial time is lost, where a curable cancer becomes an incurable cancer. And that's the part, is like, if you find something, please do something about it. Like, tell someone, seek out, even if you find a lump and it's nothing, 90% of, if you find something, it's nothing, but the 10% where it is something, don't wait 6 months, because that can really turn, as I said, from a curable cancer to an incurable one.
And do you think that's fear that is preventing them from addressing it?
Mostly fear, yeah. Fear, we call it denial, and this can have multiple aspects. It can be like people thinking they're too young, they don't have a family history, misconception. It's fears and misconceptions.
Right, and you touched upon the family history. So if somebody does have a known family history through either of their parents or their father's side, would their screening approach be different? Should they be more proactive and ask their doctor, even if it's not been recommended to them?
Yes. And that's the screening and prevention is still lagging a little bit. Let's, for example, assume someone has a BRCA mutation. Like a woman with a BRCA mutation will get screened starting with MRIs at 25. Not everyone knows that. And we start talking very early about how to prevent for ovarian cancer, and then later for pancreatic cancer. So, but that's a very different way of screening, waiting until you're 40 or starting at 25. So I think one needs to know that.
And there's a lot of research and information out there about genetic testing and epigenetic modification. What can you share about that? I think that's a little bit newer, but in some parts of the world especially. What should we be aware about when it comes to genetic testing and cancer?
Nowadays, if you have, let's say you have a mother with young breast cancer or ovarian cancer, most doctors should start talking about genetic testing. That means we take a small piece of cells in your mouth. We take a Q-tips and do a swab and test your DNA for faultiness that tells us whether someone is at risk for cancer. Now, this is not always done by every doctor and is not always paid for by insurance, but these tests are fairly inexpensive. You can get a very comprehensive genetic test for about $250 US. That's probably about 1,000 dirhams.
Little less.
About a little bit less, yeah.
So you would recommend that one would look into that for themselves?
Yes, like for example, and that speaks to the risk and how BRCA mutation are passed on. Let's assume my father had a BRCA2 mutation, right? The gene is passed on 50%. So I have a 50% chance to carry the mutation and a 50% not to carry the mutations. So now I was the unlucky one. I got the mutation. I got my mutation from my father. So if I tested my one daughter, she has a 50% chance to carry the mutation, and I have not tested her, and it's not the time before she's 20 until she's 25. So I had breast cancer at a young age, so that puts my daughter at risk for having breast cancer at a young age, right? If she carries the mutation, then she needs to be screened starting at 25. If she doesn't carry the mutation, she has a 50% chance of not carrying the mutation, then she doesn't need any screening. She also doesn't have a lot of risk for breast cancer.
Okay, and is there any minimum age to do the screening at, the genetic screening? When would it be recommended?
I usually recommend to my patient that they should not start before 25, unless if someone has a family member who has ovarian cancer at 27, we probably would start sooner. But that's actually very, very rare. Most of the time, we like to start screening between 25 and 30, closer to 25. However, I think it's more important that the person is ready. There are times in your life that you're just not ready for any kind of news. It's like if you're 25 and that's the year where you have all your finals for your law degree, that's probably not the time to get tested, right? And you probably should wait the year. Okay.
And we hear about the epigenetic modification. What exactly does that mean? And what does that mean becomes possible because of that?
So epigenetic modifications speak to what life does to you. So you're born with a set of genes, and then what the environment and life does to you. For example, if you think of bee kingdom, like the bees, the queen bee and the worker bee is actually not different genetically, but the queen bee gets different food than the worker bees. So that makes her a different animal then. Does this make sense? So it's just the food and the environment that makes the queen bee a different type of bee than the worker bee.
Right. So what your environment or lifestyle, nutrition, whatever that is, can have an impact.
Yes. So we know for many of our hereditary genes, lifestyle, nutrition, exercise makes a big difference. So we actually have a big study going on with about 10,000 patients that we're just about to go live to find out what the lifestyle changes are that make cancer. And that's an online, by the way, that's an online questionnaire that anyone in the world can participate.
Oh, really? Okay. So where would that be available for anyone watching who would be interested to know?
So it will be on the UCSF BRCA website, UCSF, University, California, San Francisco, and then BRCA.edu.
Thank you for sharing that. So if anybody would like to
go live, I think it'll go live in the next 30 days or so.
Okay, that's very exciting. So is that your most recent project that you were involved with?
It's one of my most recent projects that I've been working on for many years, actually, because I know a lot what's happening on the genes we know very little what's happening in the environment. And my lab has always been focused on epigenetic modification. So I'm very interested how lifestyle, how other medications, how drugs, how hormones can modify therapy.
That's great that you mentioned that, because I was about to ask you kind of how do you identify the right treatment for your patients. Well, before we get to that, what changes did you have to make in your lifestyle? I mean, if that's your area of kind of focus and research, how did you apply that to yourself?
Well, that's an interesting question. So before I was diagnosed, I was kind of very fit. I like to do a lot of sports. I also have a fairly good diet. I actually, I'm not overweight. I eat fairly well. So I figured, like, what can I do differently? The main issue I had is I have a little bit of a temper. I get angry more readily than I should be. So I made a very conscious decision that I do not let myself get angered. And I try not to get myself into situation where I find myself angry or upset or anything. So, and that was actually, I have to say that probably did more for my life than the breast cancer did. It's like, I have a lot more friends since I'm less angry.
Wow.
That helps.
Carried with you along.
Yeah. Oh, but I think there's I work many hours, and I'm absolutely passionate about work. And a lot of my friends told me, like, why don't you cut down on work? And I didn't want to do this. And I think the problem with stress is not as much how much you work is, but how much it gets to you, like how upset you are. And like, and I think minimizing stress is important. That doesn't mean you have to not work or not follow your passions. Just should not get angry about it.
Well, that's great advice, and definitely a timely reminder. I think all of us in our personal and professional lives can benefit from that. So back to kind of what we were talking about a moment ago. How do you determine the right plan for that patient that you're with? How is that identified? Is it a joint effort, or is it kind of, no matter what, this is the plan and it applies to most patients?
So generally, breast cancer treatment is a multidisciplinary effort, right? We need a surgeon, we need often a radiation therapist, we need a medical oncologist. So the surgeon deals with all the surgical removal of tumors. There's typically a breast surgeon and a plastic surgeon. Many times they are the same. So often breast surgeons are plastic surgeons. Then the radiation therapist, if someone has a lumpectomy, if you just take the lump out, not the whole breast, the patient with breast cancer needs radiation. And then there's chemotherapy and hormonal therapy and sometimes immunotherapy. So we have a very sophisticated way of designing the best treatment for someone. Let's say if you had a big tumor that is triple negative, does not express estrogen and progesterone receptor, and they may benefit from chemotherapy and immunotherapy, then that's the recommendation we would make. However, the person who ultimately says what the right treatment is the patient, right? So in the end, my role is to recommend the most optimal treatment. It is then for the patient to decide whether this is the right thing for her. And of course, we like to think that a patient may not have the same understanding that we do and therefore should be guided. But in the end, any treatment that we can do is only risk reduction, right? It's a matter of statistics and risk reduction. And I never would want to give chemo to a person who said, I just can't do it. Well, we'll find another way.
Right. Wow. Okay. So it's a very personalized and a collaborative approach with the patient.
That speaks to something that I want to touch upon quickly. It's like when you see a medical oncologist and when you have cancer, that becomes a long-term relationship. Yeah, because you see this doctor at least 3 to 6 months through the active treatment and then 5 to 10 years through the hormonal therapy. And this is what I think I learned from being a patient. Like, make sure this is a relationship that works on both ends. because you want to be able to trust your doctor. You want to be able to have a conversation with your doctor. If you feel like this relationship is not working, feel free to change doctors. It's like, it's, when my patients don't want to see me, that's not bad for me, right? That means like we don't have a relationship that's good for both of us. It's difficult for a doctor to take care of a patient where you don't get along well as well. As like I think you never offend, in my book, you never offend a doctor by saying, I want to see someone else. I mean, that's more ego than anything else, but this is a really important relationship because you need to be able to share your fears, you need to be able to share your concerns, and you need to be able to ask your questions, because a lot of time you have a question and you don't understand why you should have chemotherapy, and I think and you don't want to do chemotherapy. And I truly believe if someone explained carefully why the chemotherapy is so important, most people really come around and accepting it. No one wants chemotherapy. There's no one who just said like, oh, I really, really, really want chemotherapy. Everyone really is struggling with like, do I have to? And I think for us as doctors, it's important to say, why do you have to, and make this more understandable.
I think that's such a key point that you touched upon, and perhaps we don't hear enough of, but the relationship between the patient and the doctor, that's so important. And perhaps that really sets the tone of, that journey that they would experience together. Thank you so much for sharing that. And on the note of patients, have you experienced, or what would you do in the scenario where the patient may prefer alternative treatments? Does that happen often? I think I've read about it, and I've heard people kind of discuss that as a preference or a lifestyle choice. What happens when you face that with a patient, and what would you say when it comes to that?
You mean the 50% when it happens?
Is it?
Yeah, it happens all the time. This is a part of every discussion. So yes, I think everyone, when you're diagnosed with breast cancer, there's such a strong need to contribute. I mean, if we only contribute, so we contribute the treatment, the chemotherapy, the hormonal therapy, the surgery, whatever. But patients want to contribute. They want to contribute to their well-being and their care. So it's, if patients don't bring it up, it's not that it's not there. People may just not feel comfortable talking about it. There is the spiritual angle that's, I think it's important. There is the diet angle that's important. There's all the nutraceuticals and whatever vitamins you wanna take. It's like, so I typically have a very in-depth discussion about this, and I feel it's important to state that many of the nutraceuticals or herbs or added have very little research around it, and many of them actually, like the vitamins have lots of research around it. There's no benefit. There's no benefit to calcium for breast cancer. There's no benefit for vitamin D for breast cancer. There's no benefit to black cohosh, and there's no benefit to mushrooms. So we have studied that, and we studied this in very large groups. That's not to say that couldn't make you feel good. Like if you feel like you want to take mushrooms because it makes you feel good, that's not for me to say no, but it's not to replace breast cancer therapy. What we do know is like, and I would be very remiss if I didn't harp on this, is like exercise is proven to be beneficial. And I have to tell you, so when I first got to Dubai in 1992, and I was running along Sharjah on the water, it was, everyone was looking at me like I'm some kind of like extraterrestrial being. Now I'm very, very pleased to see that there's lots of people out there walking, there are lots of people out there running. So I commend the UAE for really getting around and doing a lot more exercise over the last 20 years. So it's really, I'm so happy to see this every time I come there.
Absolutely. That's a great observation. And I think that trend is growing and growing, and people are really adopting a new lifestyle, and it's not just a short-term or temporary kind of lifestyle change. Absolutely. And
it's really hard to run when it's 40 degrees or even more.
Or yeah, often more, absolutely. And looking at the global situation, I mean, I think no matter where in the world we are, there is a pandemic going on. We're all kind of, facing some change in our life or a conflict in our life due to it. Would you say that cancer patients, are they of more increased of risk of the COVID-19 infection if somebody is currently undergoing cancer treatment or has just recovered? Is there a change in their protocol that you would recommend?
In generally, the risk comes from unprotected exposure, more so than the risk of how to deal with the disease. And COVID is particularly difficult for patients who have poor exercise reserve and have heart and lung disease, diabetes, and obesity. There is some risk for being immune compromised from cancer, but the majority of cancer patients are actually not truly immune compromised. They still have enough lymphocytes to deal with the viruses. So most patients don't have an immune compromise. And we talk a lot about this, how important it is to stay with the treatment plan. At the same time, we have changed. Our patients really only come in for treatment. We have moved every treatment that is possibly doable to home treatment.
Right.
So patients don't have to come to the hospital. Now in San Francisco, I've been very fortunate. We have very few cases. But other parts of the world, it's not as much. And a lot of the treatments can be done over by having a nurse go to the home. A lot of the visits can be done over video.
Yeah, so you've seen a growing trend kind of in the teleconsult and the home care and home medicine side of it.
Now about 50% of my patients visit are now on video.
Wow, that's wonderful. I think we're seeing a similar trend here in the UAE with the home nursing requirement and at-home testing, and that you can do it. It really changes the patient experience, and perhaps in a time like now makes you a little bit more comfortable in the security of your home, I think.
Samina, like in previous years, I'll be sitting on your sofa talking to you, right?
Yeah, and that's
my time for the breast awareness month, but so now we're doing everything on video, so times are changing.
You do frequent Dubai for the yearly events, and I know you speak at the Pink It Now event, so perhaps maybe a visit sometime next year is on the horizon.
So.
Yeah. Well, Dr. Pamela, we're getting wonderful questions coming in, so I would like to start taking in some viewer questions, if that sounds good to you. Awesome. Okay. So we'll start off as a unique individual who has seen and experienced cancer from both sides, as doctor and patient. What would you say are the important points that both doctors and patients should say to one another? I think this touches upon your point about the relationship. What should both really express to one another?
Yeah, I think with any relationship, there's give and take, right? It's like, I mean, the understanding that doctors are humans is really important. And as you get to know your doctor a little bit more, you understand their personality a little bit better. Like and every doctor has their own sort of like difficulties. If a patient comes in with a stack of internet printouts that is 10 centimeters high and wants me to read all through the research that they have done and comment on it, that's probably not a very good use of my time. So I tend to not to be very receptive to discussing every opinion of every other person. So and then it's a trust issue. I mean, I really mean this. Like, if you can't trust your doctor, you will have a really hard time dealing with your disease. At the same time, from the doctor's side, I really try to understand if someone doesn't want to get treated and they have a very good reason why they don't want to accept treatment. I have patients who are very, very clear, this is my risk, and I know what the risk I'm taking by not doing this treatment, but I don't want this treatment. I'm very prepared and happy to deal with this. I also at the same time make every effort push people to accept more treatment if I think it's misconception on fears that disallows someone. I think as I said to the questioner, is like any relationship, there are going to be good days and there are going to be bad days.
Yeah, yeah. And I think that just kind of brings something to mind. How much is involvement from the patient's families and how much is it their choice? Do you find that you're also managing the family of the patient in addition to the patient? How does that usually work, that balance?
It's usually the family manages me more like than the other way around. But I think it's really, I learned the hard way is like, when you get a diagnosis of breast cancer, you go to the doctor. And remember, I had breast cancer. I knew all about this disease. I had to go see my plastic surgeon, and he tries to explain the surgery to me. But I'm really afraid of knives. And all I could think of when he talked about the scalpel, all I could think of it, didn't hear a thing, right? So I left this conversation after 30 minutes. I had not understood as simple as like, what is the surgery going to look like? So the next time I went with a friend who was a nurse, and she actually had me write out the questions that I wanted to know. And then she asked all the questions.
Okay.
And so that because I was really too nervous and dealing with this. And it's like, and you're probably laughing, you think like, well, she's a physician, how can she be nervous? But people are nervous, right? It's scary to have it's scary to go through any of this. So have write your questions and have a family member ask them, and always bring a family member. Never ever go alone. Like
That's absolutely wonderful advice, and I think we all can remember that for most situations that we're in. So, a next question we have is, and I think this is referring to family and friends and loved ones. How can we help people be more proactive when it comes to breast cancer awareness and early detection? So, if you have a loved one or somebody in your family or even a spouse, and you're trying to encourage them, and perhaps they're not comfortable with that, what would be the right way to support them?
This goes a little bit in two parts, and one is the communication around cancer, like what you say or how do you ask how someone feels, right? So there are people, they're under the persuasion that if you don't say anything or you don't talk about it, the problem doesn't exist. Well, for the person who has cancer, that problem still very much exists. Like, and it's not that easy to talk to someone who has cancer, but simple question like how you feel today, or like how is it going, then the person with the cancer can answer I'm fine, and leave it at that, or can talk more. It's like, I mean, just ask open-ended questions. Don't, and what I really think is very important, don't make ridiculous suggestions. If someone loses their hair, I have someone joking about saying, well, you don't need a hairdresser anymore. That's not helpful.
Oh,
Like that. So
yeah,
don't make helpful suggestions. And like, what most patients who have gone through cancer probably hear is like, everyone comes with recommendations. That's not very helpful either. What is helpful is like offering to go to a visit with someone, offering to pick them up from chemotherapy, offering to take them for a walk, bring food, take care of their children. I think these are the in addition to the emotional toll of having a cancer diagnosis, there's actually a pretty significant environmental toll. Like, you have to go to the doctors. Many people have small children, have children to take care of, like, what to do with the children, finding a way to help out there.
Yeah, I know that's absolutely great advice. And we have another question that is on a similar topic. So I think it will be a good transition. And it's about this question is about the readiness to know. So what does that exactly mean? I think you touched upon that at the start of the conversation. If somebody is not ready to know, what can they do to maybe mentally prepare themselves, and when is the right time to say, okay, I'm ready now?
That is actually quite a difficult question, and I think that's the most difficult question for everyone. I think in in a way, you're never quite ready to know, because that makes it final. Once you know, that's final. Once you know that you have a BRCA or BRCA mutation or you have breast cancer, you can't undo this. On the other hand, is if you're thinking of that you're not ready to know, that means you think about it every day.
Yes.
Right. So I think the not ready to know means like you're preparing yourself to know, and that can be just endless. And sometimes once you know, the treatment and the healing start, and the healing cannot start before you know.
Absolutely. And I think another key point you mentioned is once you know, you can't undo that. So perhaps you have to prepare yourself for the mindset to know it and then, map out those next steps. And we have a very specific question. Perhaps you might have answered this in the session, but I will ask it again. There is a high risk of breast cancer in my family. What age do you recommend I start getting screened, and how often should I be screened? We don't know the age of this person, but I'm guessing they're a little bit young that they're asking that question. They've not had a mammogram yet.
So what I would recommend now, if you really have a very high risk of family related breast cancer, I probably get genetic testing done. And there's UAE has many areas where you can get genetic testing done, and it's probably more affordable than it used to be years ago. And that will tell you whether you have a high risk, and with genetic mutation, you will immediately get screened. And this could also have an opportunity, as I said, like if you have a very high family risk for breast cancer, but you don't carry the mutation that the rest of the family carries, then your risk is actually very low. So this can be a huge benefit to you to know.
Absolutely, thank you.
But if there's no genetic mutations, typically high risk individual, we start screening 10 years before the youngest person has been diagnosed.
Okay, then that's been diagnosed in the family.
Yeah.
Okay, great. I'm very happy to receive the next question. I feel like it is perhaps a common question, but maybe not enough information out there. This user is saying, if I have breast implants under the muscle, is there a different way for me to give self-exams at home? I feel like I'm clueless when I try to feel for a growth.
Actually, having breast implants under the muscle makes an exam a lot easier, because the breast tissue becomes very thin, and whenever you feel a lump that's sizable, that's something we probably want to know about.
Yes.
So it's from our stand is actually easier to examine a breast with implants because the breast tissue becomes very thin.
And does it make a difference if the breast is over the muscle? Does it make it harder, or it's just equal level of?
Is if the implant is over the muscle, which is probably still very rare, that makes it not that much different. It just means it's over the muscle, but it's still under the breast. So the breast tissue is right above the implant. So anything you palpate is above the implant.
Okay. And can somebody with either kind of breast implants get a mammogram? Would that be beneficial at all?
Absolutely. There's like having breast implants does not negate the need for mammograms.
Okay. Wow. I think perhaps that might be a common misconception or concern that we'll have. So we have another question, and this again touches upon your point about lifestyle changes that we discussed earlier. So this viewer is asking, what are the recommended lifestyle changes to make as precaution? Do you recommend any specific lifestyle diets or programs? What would you say? Is there a one size fits all, keto, paleo, or what would you recommend as a precautionary step?
That goes a little bit back on how solid is evidence for any diet. There's not a lot of scientific rationale to adhere to one versus the other diet. There's one very strong scientific rationale is to not be obese and not be overweight. And having a BMI between 20 and 25 is actually quite difficult to obtain. So I would recommend whatever diet works for you. If you have to lose weight, whatever diet works for you. maintaining a reasonably balanced diet. And there's a lot of data suggesting that intermittent fasting, meaning like only eat for 8 hours and then 16 hours of fasting, there's a lot of interest in how this modifies your immune system and whether this is beneficial. There have been no data so far. But I know from many of my colleagues who does it, it really helps with the snacking. If you cannot eat for 16 hours, there's a lot of snacking that's cut down, right? So whether it has a direct benefit to the immune environment or to breast cancer, we don't know this, but it clearly restricts your caloric intake. So if that works for you, then
why not? But
yes.
Is the aim then as a precautionary step to be within your ideal BMI? Is that kind of target that every person can make and achieve it in whatever way that works for them?
Yes. Yeah.
Okay. And you mentioned it's difficult to achieve that 20 to 25. That's the ideal range. And I suppose it's maybe not common for everybody to achieve the ideal range. Is it a realistic target to have?
Yes, it should be a realistic target to have, because that's how most of us, I mean, the challenge is not to get obese ever, right? It's like losing weight is harder than not gaining it. But I also feel like if you exercise regularly, there's a lot more data that exercise is more beneficial than weight loss. If you in the position where your BMI is 26 and you just cannot lose weight, that's okay, but it's not okay not to exercise. And exercise does not mean going shopping. Exercise really means a brisk walk or running or like going to the gym or going to the treadmill.
Yeah, absolutely. We have another question, and I'm glad we have this question because I wanted to ask you this. This viewer is asking, saying that she would have liked to read your book. She's not read it yet, but can you tell us what to expect in Twisting Fate, authored by yourself?
I hope you're not ready to read my book because you're worried about anything that's fearful or not. This book was really written based on all like stories with patients and families, and it's all about how to survive breast cancer. It's not how to die from it. And going a little bit into how to communicate, how to interact, how to choose a surgeon, how to choose therapy, what comes first, what's to be expected with the therapy, and really all the strong part about breast cancer, that being a curable disease. It's really meant to have a bit of a comprehensive understanding what breast cancer is from the view of a patient.
Yeah. And at which stage in your life or during your journey did you decide to write this book? What was your thought process? Why a book? Was it your idea? Was it suggested to you?
Oh, it's like anything else in life. It's complete serendipity. I was sitting at lunch with a friend of mine who's written a book about testosterone. And he said, you should write a book. You at least have a good story. I'm only writing about testosterone. And I go like, I don't know. So, and then he connected me with his agent. And before I knew it, I had a contract for a book. And I have to say though, writing this book has been incredibly therapeutic for me. So even if no one ever read my book, it was a really good thing for me to do because it was very therapeutic. I got to put in on paper my fears, my hopes, what I see and like what I experience, and it was really an incredible experience. And it's written in a very easy way because my agent was a man who was also the agent for Nora Roberts. So you can imagine he mainly, and Ken Follett. So he likes romance novels and stories. He was not interested in something very technical. He really wanted something that was an easy read. So the book is really written in a way that it provides a lot of scientific backdrop, hopefully written in a way that's easy to read. You should be able to read it in an afternoon by the beach or in the gym while you're on the treadmill.
Wow, that's great. And would you say perhaps, having the experience of writing a book, that it's kind of cathartic, similar to journaling. Is that something you would recommend to somebody who is undergoing cancer treatment at the moment, or just to kind of help them face that experience and then move past it, similar to how it impacted you?
Yeah, I would think so.
Yeah, I think we just hear a lot of positive messages about writing your thoughts and gratitude and things like that. Um, so I'm going to take one last question for the evening, and this is a very interesting one. I'm not sure how often you get this question, but I'd love to know your thoughts. And this viewer is asking us about saying, we hear that men also get breast cancer. Can you tell us a little bit about this? Is this true?
Yes, so for every 100 women with breast cancer, there'll be one man. So male breast cancer is not that rare. Male breast cancer is typically hormone sensitive, that not always needs chemotherapy. So it's typically very well, we'd be very able to treat male breast cancer. Is not a more aggressive or a more dangerous breast cancer than female breast cancer. It's follows along the very similar treatment principles as female breast cancer. It is a lot easier to find. So any male who finds a lump should really come forward with that. And the surgery is a lot easier. It's less disfiguring. We do a very simple mastectomy, and you virtually can't see anything.
Okay, so the self-screening process is the same, looking for a lump.
Mhm.
What about the other pre-screening? I guess the women are doing mammograms and other such options. Do men have these options available as well, or it's not really?
They do. So for patients with BRCA2 mutation, male breast cancer is common. So we offer mammograms, but if someone is willing to do a breast exam, often we forego the mammogram because it's really very easy to examine the breast.
Okay, and just a question again on the family history. If a male has a family history of breast cancer, would you recommend him then to do the genetic testing similar as you would to anybody else?
So it's probably the other way around. If you have a male with breast cancer, that puts you in a much higher risk of being a mutation carrier. Um, if you have a very strong family history for female breast cancer, that not necessarily puts the men at higher risk unless it's a BRCA1 or 2 mutation, BRCA1 or 2 mutation. And the other risk factors for breast cancer don't usually travel to males, but BRCA1 and 2 do. So
They do. Okay. I know I said last question, but there's one more that I will take. It's quite an interesting one. I haven't heard this one before. Perhaps you have. What are your thoughts on a cancer patient or patient in remission getting the COVID-19 vaccination when available? Is that something that's discussed? Is it too soon to know?
I think that the decision of having cancer, unless it's metastatic cancer, where a patient is immune compromised, that decision should not weigh in. It's like, I think like you should get a COVID vaccine if once the vaccine is available and safe. That should probably not be as much influenced by your cancer. But for now, what I think is even more important, like everyone should get the flu vaccine. We really should get, we recommend that the flu vaccine is given to everyone, particularly to cancer patients. And then in terms of other vaccines, the herpes zoster vaccine is another vaccine so there's 3 vaccines that I feel very strongly about. One is the flu. One is the HPV vaccine, I think the human papillomavirus vaccine. I'm sure you have heard me talk about cervical cancer. And now the age of the HPV vaccine has now been pushed up to 40. So anyone who has not had the HPV vaccine and is between 25 and 40 should have that vaccine. And then the other one is for the people over 50 to consider the shingles vaccine. Shingles is a very common disease. So particularly shingles is very common in cancer patients.
Okay, all right. I think that's very helpful for our viewers. So on the HPV vaccine, is that just for women, or are men able to obtain that as well, or recommended to or not?
And this is a virus. The virus don't have preferences for one gender over the other. So there should be for men and women. Yeah.
Okay, wonderful. Well, that's been super helpful. And I would like to ask you, Dr. Pamela, do you have a closing message or anything you would like to share with our audience today?
Yeah, just keep in mind you're not alone in this disease, but most importantly, like at Zuleka Hospital, we really build a whole team around dealing with questions on screening, questions on mammograms, and we have a very significant team in Sharjah and Dubai and looking out for cancer patients. I think my strong recommendation is that you cannot start healing before you tackle the problem. And I think avoidance in cancer is just not a good strategy. And I think it's important. I think knowing is never as bad as not knowing and not doing anything about it.
That is
But most important is I'm really excited to be here.
absolutely. Well, it was such a pleasure to have you, and thank you for that key message. Knowing is more important than not knowing. So thank you so much, Dr. Pamela. It was a pleasure having you on this session. Really appreciate it. Thank you. I would also like to thank everyone who submitted their questions in today and logged in to watch our webinar on breast cancer awareness and research with Dr. Pamela Munster. We hope you gained some interesting insight from today's discussion, and we look forward to seeing you at the next Wellness Wednesday webinar. Thank you, everyone.
Thank
Bye.
you.